Today, we're going to talk mostly about the safe and effective use of our new oral anticoagulants. And hopefully by the end, we'll talk a little bit about the mechanisms of action, pharmacokinetics, and some of the FDA-approved indications so far for these new agents. Discuss a lot of the clinical trial data and figure out how we can select an appropriate anticoagulant for a specific patient, and describe some of the safety concerns, monitoring options, and potential reversal strategies for some of these new agents. But before we get started, I think it's good to just kind of introduce these agents and how do they work and how do they compare to our current standard of care. So here's our coagulation cascade that I think most of you are fairly familiar with. And we have our current standby warfarin. So remember, warfarin is inhibiting factors 2, 7, 9, and 10. And our new agents on the market are a little bit different. So the first one we're going to talk about today, the first one to come to market is Dabigatran, and that's our thrombin or factor 2A inhibitor. And we're also going to talk about some 10A inhibitors, so Rivaroxaban also on the market, and Apixaban, which is probably closest to being on the market. And then there are even more anti-10A agents in development, Apixaban, Apixaban. We're not really going to talk about them today, but I want you to realize that even more new agents are kind of in the pipeline, and we might start to see them in the future. So when we look at the development of oral anticoagulants in the United States, we see some pretty interesting trends in what I think is a pretty exciting time to be talking about these new agents. So we had warfarin, our first old standby that was developed back in 1954. And we had to wait over 50 years, just until 2010, to get another oral anticoagulant on the market. But as soon as we got Dabigatran, shortly thereafter, we got our second agent, Rivaroxaban. And as I said, Apixaban is probably pretty close. It's being evaluated by the FDA currently. And then those other 10A inhibitors may be in the near future. So you can see it took over 50 years before we had something new. But now that we've started to develop these agents, they're coming out faster and faster, and we have more and more options for our patients, which is very exciting. But as we kind of get to know these agents, it's very important for us to understand some of the advantages and disadvantages they have compared to traditional warfarin therapy. And amongst each agent, we kind of have to understand the pharmacokinetic differences and different safety profiles so we can kind of pick the best agent for each of our patients. And we're going to talk about each agent individually and kind of the data behind them, why they were approved, and how we should use them. But before we talk about each agent individually, I think there are some general advantages and disadvantages as a group between the new agents and our standby warfarin. So some advantages I see is that these agents are very fast onset of action, so it kind of eliminates a need for bridging that we see with traditional warfarin therapy, which is great. There's no routine lab monitoring that's required, so we don't have to check an INR, and it's kind of an easier thing for our patients to do, potentially. They do have fairly short half-lives, which can be great rapid decline in effect if you need to go to a planned procedure or surgery. You don't have to wait several days. They have a decreased number of drug-drug and drug-food interactions. Not zero, we'll talk about some of them, but definitely decreased compared to warfarin. And they're potentially more cost-effective because of that no routine monitoring, potential reduction in bleeding. They might be more cost-effective. However, they do have some serious disadvantages that we have to weigh before we select one of these agents. One is that almost all of them have some component of renal elimination. So it necessitates either a dose reduction or really not using at all in certain patient populations with severe renal dysfunction. We have a limited availability of assays to monitor these medications, which we said was an advantage. We don't have to routinely monitor them. But in certain instances of thrombosis or bleeding, it might be something we wish we could do. They have that short half-life, which again could be an advantage, but maybe a disadvantage if patients aren't as compliant. They have a quick decrease in their anticoagulant effect and potential higher risk for thrombosis. There's no specific antidote or reversal agent for these medications just yet, like we have vitamin K for warfarin therapy. So it could be potentially harmful in the case of major bleeding. And the drugs do cost more for the patient. So high drug acquisition costs might be a disadvantage for some patients. So the first drug we're going to talk about today is Dabigatran. And as I said, Dabigatran did come on the market in 2010. It's been with us for a little bit now. And it is a prodrug, Dabigatran etexylate, that undergoes hydrolytic cleavage once in vivo to Dabigatran. It doesn't have a very high bioavailability, and it's important that this medication is taken as it comes. So you can't open the capsule, break the capsule, because it reduces the bioavailability even further. And it is a substrate of the P-glycoprotein efflux transporter in the gut. So when we talk about drug interactions, think about P-glycoprotein. Its half-life is about 12 to 17 hours, and it does undergo about 80% renal clearance. And so that's also really important when we talk about some of the safety concerns with this agent. But in terms of metabolism, it doesn't really undergo any metabolism in the liver. Certainly avoids all the CYP P450 isoenzymes. So those types of drug interactions we don't have to worry about. So Dabigatran was first studied in patients with AFib in the one large clinical trial that gained its approval is the RE-LY trial, which I think a lot of you are probably familiar with. But it was a very large clinical trial. Over 18,000 patients were enrolled. And they had to have AFib with at least one risk factor for stroke. So that's hypertension, heart failure, age over 75, diabetes, or a prior stroke. And it was in 44 different countries, so a very, very large clinical trial. And they excluded patients who had heart valve disorders, so this is for non-valvular AFib, those who had a very recent stroke, those with active liver disease, and very importantly, those who had a creatinine clearance less than 30. So none of those patients were enrolled in the trial. And they were randomized to one of three arms. So either they received Warfarin, open label, so it wasn't a blinded study, or they received Dabigatran 110 milligrams twice a day, or Dabigatran 150 milligrams twice a day. And they followed these patients for about 2 years, and the primary efficacy outcome that they were looking at was the incidence of stroke or systemic embolism. And primary safety, they were looking at major bleeding. And when we look at who got into this study, what were the patient characteristics? The mean age was about 70 years old, a little higher, a little bit more men than women. The mean CHADS-2 score, so their risk of stroke, was about 2. About 20% of patients had had a previous stroke. Only about 20% of patients had reduced renal function, so moderate renal dysfunction, maybe creatinine clearance 30 to 50. Which I think is important to note, since we know 80% of this drug is eliminated by the kidneys. We didn't have a large portion of patients in this trial who had any moderate renal dysfunction. And the time in therapeutic range in the Warfarin arm was about 64%, which is pretty good standard of care for adequate Warfarin therapy. And when we look at the results for the primary efficacy outcome, we have on the top the Dabigatran 110 milligram dose versus Warfarin. And we can see that it was found to be non-inferior to Coumadin in reducing stroke or systemic embolism, but it wasn't superior. But it was not inferior. And when we look at the Dabigatran 150 milligram dose compared to Warfarin, we see that it was non-inferior and then tested for superiority, and was also found to be superior to Warfarin in reducing that stroke and systemic embolism. And of course, the other main thing we're looking at is bleeding with all these anticoagulants. And when we looked at bleeding, we see that the Dabigatran 110 milligram dose actually reduced bleeding events compared to Warfarin therapy, while the Dabigatran 150 milligram dose was about the same as Warfarin. Okay? Some things that I think are important to look at when we look at the safety of this drug to kind of tease out with this bleeding. On the left, you can see the sites of bleeding with both the 110 milligram dose and the 150 milligram dose compared to Warfarin. And with the 150 milligram dose, you can see that there was actually an increase in gastrointestinal bleeding compared to Warfarin. but a decrease in intracranial hemorrhage. So that kind of no difference in bleeding is balanced out. A little more GI bleeding, less intracranial hemorrhage. Additionally, when we think about anticoagulants, almost always we're thinking about what is the risk of bleeding. That's our main side effect, the thing we're worried about the most. But Dabigatran actually has one other somewhat significant side effect that was noted in the RE-LY trial, and that was incidence of dyspepsia. Both doses of Dabigatran significantly increased the rate of dyspepsia and actually led to discontinuation in about 20% of patients in the trial. So it's just kind of one other thing we should be looking out for our patients, since that did occur more often than with the warfarin arm. So conclusions that we can take away from RE-LY, or what I think is kind of the summary of this trial, is that the Dabigatran 110 milligram dose was non-inferior to warfarin in preventing stroke and significantly reduced bleeding. And the Dabigatran 150 milligram dose significantly reduced stroke and systemic embolism and came with a similar rate of major bleeding. But remember, that was a little more GI bleeding and less intracranial hemorrhage. But both doses do reduce the risk of intracranial hemorrhage, and both doses increase that risk of dyspepsia. So based on this trial, we now have Dabigatran on the market here in the United States. But what's interesting is that both the United States, the European Union, and the Canadian regulatory bodies all took a look at this data and kind of interpreted it in slightly different ways and approved slightly different doses. So here in the United States, only the 150 milligram dose was approved to be given twice a day. And that was probably because they wanted to ensure increased use of the most efficacious dose. So they didn't offer the 110 milligram dose. But they did suggest that a dose of 75 milligrams twice a day could be used in patients whose creatinine clearance is 15 to 30. Now, this is a little bit controversial because, as I said, in the big RE-LY trial, they excluded patients who had a creatinine clearance less than 30, right? So this dosing recommendation is based on some pharmacokinetic studies, and it really hasn't been studied in patients with AFib at this time, so it's a little less known as to how that will pan out. In the European Union and Canada, they actually chose to approve both doses with some slightly different restrictions. So they approved the 150 milligram dose. They also approved the 110 milligram dose and said that should be used if patients were over 80 years old. And I'll show you some of that data relating to age and risk of bleeding in just a second, kind of understand why that was chosen. And they chose to be a little bit more conservative, more indicative of what was done in the trial, and actually suggest the drug not be used in anyone whose creatinine clearance is less than 30. So we have this very large clinical trial of 18,000 patients, and overall, we kind of talked about some of the key results. But what I think is really important is to kind of look at all of our special patient populations that fall, that we see every day, who might have increased exposure to Dabigatran, and it might change the overall efficacy and safety that we saw in RE-LY. So those are patients with advanced age, patients with renal dysfunction, or those who have significant drug-drug interactions, and how does that change how we should be using this drug? So we'll talk about all of these. So first, we'll talk about age. So we already know that as people age, they're often at higher risk for bleeding. They often have decrease in renal function. And so this was looked at in the RE-LY trial. So this first graph in red shows the impact of age on major bleeding. So they looked at patients who were less than 80 years of age, and then patients who were greater than 80 years of age. And they compared the rates of bleeding compared to warfarin in those two groups. And as you can see, in patients who are less than 80 years of age, there was really no difference between the Dabigatran and warfarin groups in terms of bleeding, just like we saw with the overall trial. But in patients who were greater than 80 years of age, in that 150 milligram group, we see a significant increase in bleeding compared to warfarin. And this is sort of what the European Union and the Canadian regulatory bodies use to decide if you're over 80, you should only be using the 110 milligram dose. I think we all know that as people age, their renal function declines, and sometimes it's hard to tease out, is it age alone that's playing a role in increasing rates of bleeding, or is it because their renal function is kind of declining along with their age? And so this was looked at, again, in the RE-LY trial. The second graph here is a subset of patients from RE-LY, and they took all the patients who creatinine clearance was greater than 60 mils per minute, so fairly normal renal function, and split them, again, into age groups. So less than 65, 65 to 75, and those over 75. And as you can see, as age declines, the kind of risk of bleeding with Dabigatran does go up. Now, this last group here, age greater than 75, it didn't reach statistical significance in causing an increase in bleeding, but you can kind of see that the shift leads us to think that the risk is probably greater, and there were not that many patients over age 75, so our numbers are small, so it might have been a reason it didn't reach statistical significance, and that confidence interval is quite wide. And so it's not that someone over age 75 should use this drug, but understand that they're probably exposed to more Dabigatran than someone younger, and their risk of bleeding might be slightly higher. The second sort of special patient population that I think is important to look at is renal function specifically, because we said 80% of this drug is cleared by the kidneys. And this is a pharmacokinetic study in healthy volunteers. They gave them one dose of 150 milligrams of Dabigatran, and then they compared the AUC and the Cmax of patients who had mild renal impairment, moderate renal impairment, and severe renal impairment to those healthy volunteers who had no renal impairment. And as you can see, as renal impairment declines, the AUC, or exposure to Dabigatran, significantly increases. So in our mild renal impairment patients, we see a slight increase in AUC. Those probably patients whose creatinine clearance is between 50 and 80. It didn't really reach statistical significance. The severe renal impairment patients, that third line, had over a 6-fold increase in exposure to Dabigatran, that AUC. And so this is some of the data that the FDA used to say we should be using a 75 milligram dose twice a day. But what I think is probably even the trickiest population are those patients with moderate renal dysfunction. So creatinine clearance between 30 and 50 mils per minute. You can see they have over a 3-fold increase in AUC with Dabigatran, but currently there's no recommendation to reduce the dose of Dabigatran at this time. And then the last patient population, or special situation, I think we kind of need to look at is those with drug interactions. So we already talked a little bit about the pharmacokinetics of this agent. And we said it's not a substrate of those cytochrome P450 enzymes, so we don't really have to worry about drug interactions there. But it is a substrate of the P-glycoprotein efflux transporter. So we are kind of worried about interactions or drugs that inhibit or induce P-glycoprotein. And there are several, of course, drugs on the market that have an effect on P-glycoprotein. Amiodarone is one. It showed a small increase in the AUC of Dabigatran, but was actually offset by some increase in renal clearance, so there's currently no dose adjustment there. But other drugs like ketoconazole have significant increases in AUC and Cmax when combined with Dabigatran. However, the FDA generally uses a cutoff of about an increase of 150% to say a drug shouldn't be used together. So there's currently no dose adjustment recommended in the United States for patients who have normal renal function if they're on ketoconazole. And similarly, with verapamil and dronedarone, we see increases in the AUC when combined with Dabigatran, but currently no dose adjustments are recommended at this time. In terms of inducers, we know that rifampin or other drugs like that can induce P-glycoprotein will cause a significant decrease in Dabigatran exposure, reduce efficacy potentially, and so currently co-administration is not recommended. Of course, there are lots of other drugs out there on the market that haven't really been evaluated in pharmacokinetic studies, but we know a lot of the pharmacokinetic properties of those agents, and we can predict that they might potentially also have some drug interactions with Dabigatran. So our protease inhibitors, like ritonavir, definitely inhibits P-glycoprotein and probably will increase dabigatran exposure. Our calcineurin inhibitors like cyclosporin and tacrolimus, similar potential interactions. And then, of course, other azole antifungals like itraconazole or posaconazole have the potential to inhibit PGP and cause an increase in dabigatran exposure. So all things to kind of keep in mind when you're selecting dabigatran in a particular patient. So now I want to introduce you to a patient. Her name is JB, and we're going to talk about her several times throughout this presentation. So based on what we talked about the pharmacokinetics of dabigatran, JB was in your clinic, and she's 78 years old. That's all you really know about her right now. Would you feel comfortable still giving her dabigatran 150 milligrams twice a day? No. Really? She's 78. There was no increase in bleeding, maybe a little extra exposure. No one wants to give her dabigatran? Okay. Well, I don't know if everyone would agree with you. Maybe I've biased you a little bit. But I think, in general, people are still using this agent, even in our older population. But I think what is more compelling is, what if I also told you she was on Rapamil for her AFib for rate control? Then I think we already know she's got some age plus a drug interaction. It's a little scarier. And what if I also told you she has some moderate renal dysfunction? She's kind of in that 30 to 50 mils per minute group. So this is what I think is really the perfect storm. When we see each of these small changes, age, renal function, a moderate drug interaction, that increase exposure to dabigatran slightly, but when combined all together in one patient can be potentially dangerous, and probably in this situation, the risk outweighs the benefit. So things to keep in mind. And what's nice is that the FDA has recognized this, that P-glycoprotein inhibition and impaired renal function are the major independent factors that result in increased dabigatran exposure. So just recently, actually, the package insert was updated to reflect some of this information. At first, it wasn't in there at all. And they recommend to assess renal function during therapy and as clinically indicated, and to discontinue dabigatran in patients who are in acute renal failure. They actually have a statement to recommend to reduce the dose to that 75 milligrams twice a day when dronedarone or ketoconazole, those moderate PGP inhibitors, are co-administered in a patient with moderate renal impairment. And to avoid it completely, if you use a moderate moderate PGP inhibitor and severe renal impairment. I think these are great recommendations, and we are finally recognized that when you combine two pathways of dabigatran elimination, when you inhibit both of them, you have an increased risk of exposure. I think potentially one could argue to not use this agent at all in patients with reduced renal function and a drug interaction, instead of just going down to that 75 milligram dose, since it's really never been studied in patients with AFib. All right. So the next drug we're going to talk about is Rivaroxaban. And Rivaroxaban, remember, is that 10A inhibitor. It has a much higher bioavailability than dabigatran, 80 to 100%, but it is dependent on food, so it's recommended that it's administered with a meal. And it, too, is a substrate of that P-glycoprotein reflux transporter. Its half-life is a little bit shorter than dabigatran. What's nice, though, is that its elimination is less reliant on renal function, so only about 30 to 40% of the drug is eliminated by the kidneys. However, it has an additional caveat in that it's metabolized by cytochrome P450-3A4. So a little bit more potential for drug interactions, a little bit reduction in reliance on renal function for clearance. And Rivaroxaban was evaluated, again, in a large study of over 14,000 patients called the ROCKET-AF study. And this was, again, a very large, multi-center clinical trial in patients with AFib. And they randomized patients to receive Warfarin. This time, Warfarin was actually administered in a blinded fashion with blinded INRs, as opposed to open label, as we saw with RE-LY, or to Rivaroxaban 20 milligrams daily. However, in patients who had that moderate renal dysfunction, they actually had a dose of 15 milligrams per day. They included patients, who were a little bit higher risk than those in the RE-LY trial. So they had to have either a stroke or TIA previously, or at least 2 other additional risk factors. And they excluded, very similar to RE-LY, patients with valves, recent stroke, active bleeding, or granny clearance less than 30 again. They again followed patients for about 2 years, not quite 2 years, and looked at that primary efficacy endpoint of stroke or non-CNS systemic embolism. And for safety, they again looked at major or non-major clinically relevant bleeding. And so when we look at the baseline characteristics of ROCKET, we see it was a little bit different patient population than we saw in the RE-LY trial. So about the same age, about the same number of men and women, but much higher CHADS-2 scores, about 3.5 compared to about 2 in RE-LY. Many more patients had had a prior stroke, about over 50%, compared to about 20% we saw with RE-LY. That moderate renal dysfunction group, still only about 20% of patients had that reduced dose to 15 milligrams. And the time in therapeutic range in the warfarin arm was about 55%, which was lower than what was seen in RE-LY, and has been the focus of some criticism of this trial. But the way they calculate time in therapeutic range did differ slightly between the trials. So it's not 100% the warfarin arm in this trial was that much worse than the warfarin arm in RE-LY. All right, so when we look at the efficacy of Rivaroxaban in this population, they actually compared Rivaroxaban to warfarin in 3 different analyses. And the first analysis was the per protocol analysis, and they first tested this for non-inferiority. And the per protocol analysis was patients who received at least 1 dose of the drug, who had no protocol violations, and who were not lost to follow-up. And they found that Rivaroxaban was non-inferior to warfarin for preventing that stroke and non-CNS embolism. And second, they looked at their safety population and tested it for superiority. And the safety population was those who received at least 1 dose of the drug and were not lost to follow-up. And they found that Rivaroxaban was superior to warfarin in that safety population. And then lastly, to kind of confirm everything that they had done, they decided to look at their intent to treat population, so that's everyone who ever received 1 dose of the drug, and looked at superiority and non-inferiority, and found that Rivaroxaban was non-inferior to warfarin, but it wasn't superior. When we look at safety in this trial, we see very similar things to what we saw in RE-LY. There was very similar rates of major and non-major clinically relevant bleeding, so that primary safety endpoint. Again, we saw an increase in gastrointestinal hemorrhage with this agent, accompanied by a decrease of intracranial hemorrhage. So, conclusions from RE-LY, to kind of sum it up, I think Rivaroxaban was non-inferior to warfarin for prevention of stroke in 2 of their analyses, and it was superior to warfarin while patients were taking the study drug in that 1 safety population. I think most people conclude that it's probably non-inferior at least, and some have given some criticism to having only 1 population showing superiority, so it's probably, they don't want to call it superior. In terms of safety, similar rates of bleeding with warfarin, less intracranial hemorrhage, but that increased risk of bleeding. But no dyspepsia or other side effects outside of bleeding were seen in this trial. But again, with our overall results, it's important for us to look at some special patient populations that might change the safety and efficacy of Rivaroxaban. And the same 3 special patient populations still apply to this agent. So age, again, they took data from the ROCKET trial and grouped patients less than 65 years of age, 65 to 75 years of age, or those greater than 75, and found that by the time they looked at patients who were older, there was significant increase in bleeding with Rivaroxaban compared to warfarin in those over age 75, which we didn't see in the younger patient population. In terms of renal function, we again see somewhat similar things that we saw with Dabigatran, but much, much reduced. So this is, again, a pharmacokinetic study in healthy volunteers, giving them a single dose of Rivaroxaban and looking at the AUC and Cmax of patients with mild impairment, moderate impairment, and severe impairment compared to people who had no renal dysfunction at all. And as you can see, as renal impairment declines, or as renal impairment increases, we see an increase in AUC of Rivaroxaban compared to those healthy controls. Now, the magnitude of that increase is significantly less than we saw with Dabigatran, right? We saw a 6-fold increase in our severe renal impairment with Dabigatran, but we're seeing about a 1.6-fold increase with Rivaroxaban, which makes sense because only about 30 to 40% of the drug is cleared by the kidneys. And this was confirmed. They looked at the renal impairment population within the ROCKET trial, so those patients who got that 15 milligram dose, and looked at the primary efficacy outcome and primary safety outcome, and saw that they were very similar between warfarin and Rivaroxaban, suggesting that that slightly reduced dose was probably appropriate in that trial, as the efficacy results and the safety results in this subgroup kind of mimic the overall trial. Okay, drug interactions are also really important with Rivaroxaban, maybe even more so than with Dabigatran, because they have P450 elimination as well as P-glycoprotein. So there's a little bit more guidance for us with Rivaroxaban in terms of our strong P-glycoprotein inhibitors and 3A4 inhibitors. So ketoconazole and ritonavir significantly increase the AUC of Rivaroxaban and are not recommended for use together. Rifampin, again, that induces that P-glycoprotein and 3A4, will significantly reduce the efficacy of Rivaroxaban and is not recommended for use. But what I think is probably, the hardest thing to figure out is we do not have any pharmacokinetic studies evaluating concomitant administration of Rivaroxaban and drugs that are sort of moderate inhibitors of 3A4 and P-glycoprotein. So amiodarone, verapamil, diltiazem, dronedarone, drugs that we think would probably use in an AFib population and have the potential to have some drug interactions. But we don't really have any hard pharmacokinetic studies along with Rivaroxaban. However, Rivaroxaban did, again, update their package insert when it was approved for the use in AFib to kind of at least address this issue. They recommend to assess renal function, because it is still an important pathway in the elimination of Rivaroxaban, and to discontinue in acute renal failure. They recommend avoiding concomitant use of Rivaroxaban and those strong inhibitors, so that's your ketoconazole and ritonavir. And they do recognize that in patients with renal impairment who also receive drugs that are moderate inhibitors of P-glycoprotein or 3A4, so your amiodarones, dronadarones, verapamil, they might have significant exposure compared to patients who don't have renal dysfunction or a drug interaction. And so they recommend to only use the combination of moderate renal dysfunction and one of these moderate inhibitors if the benefit outweighs the risk. They don't give you a lot of guidance as to when the benefit might outweigh the risk, but I would argue that it probably doesn't occur very often, and we should probably be avoiding use of Rivaroxaban in moderate renal dysfunction and a drug interaction, just because we're going to see increases in exposure. And then the last drug I want to talk about is Apixaban, which is not on the market yet. It's currently evaluated by the FDA. They postponed their decision as to whether or not they're going to approve it. They're waiting on a little bit more data. But I have a feeling that it will be approved as well. Remember, it's a 10A inhibitor, so it's actually very similar to Rivaroxaban. It's going to have a lot of the same drug interactions because it, again, is a PGP substrate as well as a 3A4 substrate. It undergoes even less renal elimination and its half-life is about 12 hours, very similar to Dabigatran. So a little bit longer half-life than we saw with Rivaroxaban. And although not approved today, Apixaban has been evaluated in one large clinical trial, the ARISTOTLE trial. And this again was over 18,000 patients who were randomized to receive either Apixaban or Warfarin. They were able to blind the Warfarin in this trial as well. And inclusion criteria were presence of AFib and then at least one additional risk factor. So this patient population is more similar to what we saw in RE-LY, not quite as high risk as we saw with Rocket. And they again excluded very similar patients, those with mechanical valves, severe renal insufficiency, specifically creatinine clearance less than 25 this time they picked. And the dose of Apixaban they used was 5 milligrams twice a day. And they did allow for a reduced dose, 2.5 milligrams twice a day in selected patients. And selected patients had to have 2 of either age greater than 80, a body weight less than 60 kilos, or serum creatinine greater than 1.5. So as these drugs are starting to come to market, and we're learning a little bit more about them, we're starting to think about age and reducing doses, think about renal dysfunction and reducing doses. And so I think as we continue to see these agents, more and more dose adjustments you're going to see built into clinical trials. The primary outcome they looked at, again, very similar, stroke or systemic embolism, primary safety, major bleeding, and again, followed patients for about 2 years. So as I said, the baseline characteristics in ARISTOTLE are very similar to our patients we saw in RE-LY. Age about 70, similar numbers of men and women, and that CHADS-2 score, that risk of stroke, was about 2 again. About 20% of patients had had a previous stroke, very similar to RE-LY, much less than what we saw with Rocket. Number of patients who received that reduced dose, that 2.5 twice a day, was actually very small, so it's very hard to evaluate. Only about less than 5% of patients actually received that dose. And then the Warfarin use was fairly adequate in this trial. About 62% of the time patients were in therapeutic range. When we look at the primary outcome, again, stroke or systemic embolism, we see that Apixaban, compared to Warfarin, significantly reduced the rate of stroke or systemic embolism. And they did, again, several analyses to evaluate this. First, they tested it for non-inferiority, which it met. Then they tested it for superiority, which again they met, found it was superior to Warfarin therapy. And then lastly, as a pre-planned analysis, they did decide to evaluate this at the difference in all-cause mortality and found that Apixaban significantly reduced mortality compared to Warfarin therapy. And it's the only agent so far to sort of show that compared to Warfarin. All the other ones reduce stroke and things, but Apixaban is the only one that's shown a decrease in mortality. In terms of major bleeding, again, very positive results with Apixaban, significantly reduced bleeding compared to Warfarin by about 31%, so big drops. And when we look at the bleeding in ARISTOTLE, we're seeing kind of a little bit different than what we saw with the Rivaroxaban and the Dabigatran, in that we do still see that significant decrease in intracranial hemorrhage, but we do not see an increase in gastrointestinal hemorrhage. So it's not a balance out, it's just significantly reduced. So again, treatment with Apixaban definitely reduced stroke and systemic embolism by about 21%, reduced major bleeding significantly without increasing GI bleeding, and it did reduce mortality. So it has potential, and it may be here soon. Our use in special patient populations with this agent is even more limited. Even less pharmacokinetic studies have been published. We don't have all the analysis from the ARISTOTLE trial the way we do with Rocket and RE-LY, but knowing the pharmacokinetics of the drug, it's very similar in its elimination to Rivaroxaban. So I think we can predict some of the very similar drug interactions. Age, we don't really know a lot, and we know a reduced dose was used, so it's probably something we need to look for. And in terms of renal function, creatinine clearance less than 25 was definitely excluded from this study. So those are probably patients we shouldn't use this drug in. We know that it has much reduced reliance on renal clearance, and so our worry with renal function might be less than with the other agents, but still it's part of the elimination pathway. So again, in a patient who has multiple avenues of Apixaban elimination blocked, we could start to see increases in exposure. Okay, so let's come back to JB for a little bit here. So remember her, she was our patient who you guys didn't want to give Dabigatran to, because she was 78 and on verapamil and had reduced renal function. So luckily for you guys, we were right on, and they actually decided not to use Dabigatran, and instead they started her on Rivaroxaban. And she was doing well, but now she's scheduled to undergo a cardiac catheterization, elective procedure for some worsening angina. Her past medical history, she has diabetes, hypertension, AFib, obviously, coronary artery disease, and GERD. And her home medications include the following. Probably the things to mostly note is she is on Rivaroxaban, that reduced dose, and she's on diltiazem, kind of a moderate 3/8/4 and PGP inhibitor. And her pertinent laboratory values, her serum creatinine is at baseline, her creatinine clearance is around 40, and the rest of her labs look pretty good. So the question is, how long should JB stop her Rivaroxaban prior to her procedure? And how do we know how long we should hold this drug for? Well, luckily for us, two of these agents are on the market, so they have package inserts, and we have some guidance from the companies and from some of the pharmacokinetic studies to help us understand how do we use these drugs safely in a perioperative setting. So for Dabigatran, it's recommended if your renal function is greater than 50 mils per minute, you should stop it about 1 to 2 days before the procedure. And if your creatinine clearance is reduced, your half-life is most likely going to be quite a bit longer, and so they recommend to discontinue 3 to 5 days before the procedure. Again, they also state that we should be considering longer times for patients undergoing major surgery or spinal puncture, where complete hemostasis would be required. Better safe than sorry. For Rivaroxaban, the package insert recommends that we should discontinue at least 24 hours before the procedure, which is helpful, but not particularly helpful. And I think we could potentially make some educated decisions about more specific recommendations and when to reduce this drug. So if your creatinine clearance is greater than 50 mils per minute, discontinuing 1 to 2 days before the procedure is probably reasonable. We know the half-life is about 5 to 9 hours. But if your creatinine clearance is less than 50 mils per minute, it's probably adequate to discontinue probably 2 to 3 days before the procedure. A little bit longer times because we know renal elimination is going to play a role. And even in the package insert for Rivaroxaban, extended half-lives have been seen in patients with renal dysfunction and older patients up to 11 to 13 hours. So kind of thinking about your patient who is taking that drug and what other factors are going on with them will help you pick how long should I really be holding this drug. Apixaban, obviously not on the market, so it doesn't have any formal recommendations, but just based on the half-life, it's probably similar to Dabigatran. And in addition to looking at the half-life and how long to hold these agents, I think we also have to take into account our special patient populations that we talked about. So in an elderly patient who has a drug interaction and has some reduced renal impairment, I think we can easily conclude that their half-life is going to be even longer, and holding the drug for even longer than what we would typically recommend might be prudent. So consider extending some of your discontinuation times or even increasing monitoring to assess bleeding risk. So I know we said we don't monitor these drugs, right? No routine monitoring, and that's what makes them so great and easy to use. However, there are times when you might want to know how much of these anticoagulants are hanging around in a patient. Obviously, in our patient, it would be great to know when is her Rivaroxaban really out of her system. Or in a patient who presents with bleeding or thrombosis, we might want to know how much drug is on board, or is there any drug on board in this patient? So I think these monitoring tests, we'll talk about them. Your most common anticoagulant tests, your APTT, your PT, and your INR, can be used and are still valuable for these agents if used appropriately. So with warfarin, we all know that we have a therapeutic range for the INR, it's 2 to 3, and that therapeutic range has been linked in multiple studies to the safety and efficacy of warfarin. But with these agents, we don't have that luxury. We don't have an INR range that's going to tell you that these drugs are therapeutic or can guarantee you good safety or good efficacy. But rather, these tests can help us determine if a drug is present in a patient who's bleeding or thrombosing. So when we look at Dabigatran, our most common test we could use, that PTT is probably the most sensitive to Dabigatran concentrations. And we know that it does increase with increasing plasma concentrations of Dabigatran. So if you have a patient who's going for an invasive procedure, who's on Dabigatran, and you check their PTT and it's elevated, you might want to wait a little bit and let that Dabigatran come out of their system, because you know it's still hanging around, causing an elevation in that PTT. The PT and INR are actually relatively insensitive to Dabigatran and are often normal in patients who take Dabigatran. They can be increased when you see supratherapeutic concentrations and high toxicities, but generally looking at the PTT is probably the best way to know if there's any Dabigatran hanging around. Rivaroxaban and Apixaban, probably the most sensitive is the PT. All three, PTT, PT, and INR, will increase with increasing Rivaroxaban concentrations, but the PTT and the INR are more variable and not quite as sensitive, and so they actually recommend that probably the PT is the best thing to look at when you're evaluating, is Rivaroxaban still playing a role in this patient. And these tests, the PTT, the PT, and INR, although not particularly sensitive or perfect, we know that they're readily available in almost every hospital laboratory, and so they're easy to obtain and easy to look at. Now, there are other anticoagulant tests that are also available to help us kind of figure out, is there a drug on board in this patient? But unfortunately, a lot of these tests aren't routinely available at most hospitals. So the Accreditation clotting time and thrombin time, these both measure thrombin activity or thrombin generation. And so they're fairly useful for monitoring Dabigatran. They're more sensitive and precise probably than the PTT. It's just a lot of hospitals don't have access to them. I know we don't at our institution, so we're kind of using PTT as our best surrogate. But since they measure thrombin activity and thrombin generation, they don't really have a role with our 10A inhibitors, Rivaroxaban or Apixaban. The most promising assays that I think maybe we'll start to think about using in the future that are probably the most sensitive are the chromogenic assays, or those anti-factor 2A, anti-10A assays. We already have anti-10A assays. A lot of hospitals use them to monitor low molecular weight heparins or heparin. Obviously, we don't have them calibrated for our Rivaroxaban or Apixaban at this time, but they are very sensitive and they measure directly the effect of the drug on these factors. And there's no developed anti-factor 2A assay currently, but there's a lot of talk about this being developed and these being the way we should be doing it in the future, since they're much more sensitive. Okay, so back to JB. If she's going to go to cath, remember her, she has some moderate renal dysfunction. Creatinine clearance was about 38. She was on Rivaroxaban and diltiazem. So how long do you guys think we should hold her Rivaroxaban? How many people want to hold it for 2 days? Okay, I got a couple. How many 1 day? That might be a little short. How many would want to hold it for 4 days and consider checking some PTTs or PT to ensure it's eliminated? Okay, I see more. Yeah, I kind of agree. So I would say we should be holding it for at least 2 to 3 days. We know she has reduced renal function and a drug interaction. You could consider even longer. And just checking a PTT or a PT in her will help give you such a good sense of if she still has any drug on board. It would be safe for her to go to her elective procedure. So she ends up having it held for 3.5 days. She comes to the cath lab. Her PT and her PTT are normal, and she undergoes the procedure without complication. However, 8 months later, she comes back. She has abdominal pain and reports a 1-week history of black tarry stools. Her home medications are unchanged, but her laboratory values are a little bit out of normal now. She has an increase in her serum creatinine, a drop in hemoglobin and hematocrit. And when we look at her coagulation parameters, she has an elevated PTT, elevated PT, and elevated INR. So she's being admitted to us with suspected GI bleed. And if the decision to reverse anticoagulation is made, sort of what can we do with a person on Rivaroxaban? And so new anticoagulant reversal, I want to touch on it a little bit. I really think it could probably be a presentation in and of itself. It's very complex, and there's a lot of new data coming out, and it's important to interpret it properly, but I do want to touch on it a little bit. So one of the key things I think is that vitamin K does not have any role in the reversal of these new agents, despite our drugs, when they become super therapeutic, and elevate the INR, like at JB. She has an INR of 2.3, but vitamin K is not the answer for her. Hemodialysis can actually be used to remove Dabigatran, and it's recommended in the package insert to do so, but it probably is not effective for Rivaroxaban or Apixaban, so that's an important distinction. But what most people are kind of interested in talking about or hearing about, or what seems to be being used more and more, are using prothrombin complex concentrates, or PCCs, or factor 7A. And so when we look at prothrombin complex concentrates, or these PCCs, I think it's important to first kind of understand what these products are and how there are numerous products and how they differ. So there are 3 factor PCCs, those that contain factors 2, 9, and 10, like Profil 9 or Bibulin, and these are available in the United States. There are 4 factor PCCs that also contain some factor 7, Octaplex, Cofact, but unfortunately these agents are not available in the United States. And then there is one product that's an activated 4-factor PCC that contains activated factor 7 along with its other factors, or FIBA. And this is available in the United States. And it's important to know the differences because in the very limited amount of studies we have looking at reversal of these agents, they all use slightly different PCCs. And when you're kind of taking into account, could I use PCC in this situation, you would want to know what PCC was actually used in a particular study. Most actually use the 4-factor PCCs, and which are not available in the United States. One small study did look at using FIBA with some mixed results with that activated 4-factor. And so this is just a graph just to give you a little taste of kind of what's out there right now. But looking at PCCs, either the 4-factor or the activated 4-factor, those are the ones that have been evaluated, we see some generally promising results with Rivaroxaban reversal. And reversal meaning they reverse anticoagulation tests like PT and PTT in healthy volunteers, or they were able to stop some bleeding in an animal model. With Dabigatran, we see a little bit more mixed results. Some studies showing a more positive reversal, others showing wasn't quite as robust data showing that it could reverse some of the parameters, but did reduce in some animal models. But I think the key thing to point out is that none of them have been studied in a bleeding human. And so we really don't know what's going to happen if a patient presents with hemorrhage, with increases in Rivaroxaban or Dabigatran. But what we have is some data to help guide us on what could potentially be useful. And then factor 7A has also been studied, again reversing those anticoagulant tests in healthy volunteers. or reversing bleeding in an animal model, with again, kind of mixed results, some showing positive effects, some showing it might not be as effective. But sort of these are the two agents and two types of things we can use at this time to help us reverse, and it's probably our best guess at this time as we wait kind of for more data to come out. So if JB came in on Rivaroxaban with a GI bleed, and we wanted to potentially have an option to reverse her Rivaroxaban, what can we do for her? Can we give her vitamin K?
No.
No way. Can we give her FIBA?
Yes.
We could give her FIBA. Could we initiate hemodialysis? No. So FIBA would be our potential option. Again, the efficacy is kind of in question, but it's probably the best thing we have so far. So when we look at the present and the future, all of these agents we talked about today, mostly in AFib, right? But they're being studied for multiple indications in multiple clinical trials and have, different indications coming out more and more. So we see it in VTE prophylaxis, in orthopedic, or in the medically ill. We're seeing it for the treatment of VTE. We're seeing it in AFib and in acute coronary syndromes. And what I think is important to note is that today, only Rivaroxaban and Dabigatran are approved. Dabigatran is only approved for atrial fibrillation. Rivaroxaban is approved for AFib as well as orthopedic surgery for prevention of VTE. And Apixaban, I said, we're still waiting on. But what's key to note, for all these indications, all of the doses of all of these agents are slightly different. And so when we start to use these agents in clinical practice, we can't just know what the dose is. We have to know the indication to know if it's an appropriate dose. And things are going to change, and it will depend on renal function. So it's kind of complex. And I think it's really important for us as pharmacists to understand the differences between these agents and the slight changes in dose that are how they've been studied to make sure we're using these agents appropriately. So as you can see, the lighter boxes are the only things that are currently FDA approved. So to kind of conclude, I think that these new agents offer some of our new treatment options, the first new options in over 50 years, which is very exciting. We're in kind of an exciting time. But they come with some distinct advantages and disadvantages over traditional warfarin therapy. And I think it's key for us to understand the pharmacokinetics, the drug interactions, the monitoring parameters, and potential reversal strategies of all of these agents together and separately to help guide their safe use. Because if we don't understand these small nuances as new drugs come to market or a patient comes in on a totally different home medication, but it inhibits PGP or 3A4, you have to kind of use that knowledge of the pharmacokinetics of these drugs to understand how to use them safely.